if I asked you to picture a patient with cerebral palsy, you would almost certainly picture a child.
Right, yeah, most people do.
But, I mean, here's a statistic that completely shatters that assumption. In some parts of the world, adults with CP outnumber children with CP by roughly 3 to 1.
Wow.
3 to 1.
Yeah.
So today, we are diving into a medical discussion transcript that reveals a massive systemic blind spot in how society, and really the medical establishment itself, views a highly recognized condition.
It is a staggering ratio, honestly. And it just exposes a profound factual error in how we, teach and perceive the condition.
Yeah.
Because we have historically framed cerebral palsy almost exclusively as a pediatric disease. But it's a lifelong condition, and the adult population living with it is substantial. So the mission of our deep dive today is to correct this misconception and explore exactly what happens when these patients basically age out of a system that, frankly, was never built to support their adult lives.
Okay, let's unpack this, because if 3/4 of the patient population are adults, how did medical education and society get this so mathematically backward?
That is the big question.
Right, like, why is the vast majority of the literature, the training, the funding, why is it so heavily skewed toward pediatrics?
Well, the sources attribute this to a phenomenon called historical inertia.
Historical inertia.
Yeah. Cerebral palsy originates from a brain injury occurring before, during, or shortly after birth. So because the onset is neonatal or, early childhood, the initial diagnosis and those critical early intervention...
All the intensive stuff.
Exactly. The intensive management has historically fallen squarely on the shoulders of pediatricians and pediatric neurologists.
Right, that makes sense.
Yeah, they're the ones who define the care protocols over the decades. Consequently, the entire ecosystem of care, so the specialized clinics, the research centers, the funding streams, it all grew up almost entirely within the pediatric ward.
So it's like you're driving on this beautifully paved, multi-lane highway, right? You've got clear signs, well-lit toll booths, rest stops, emergency lanes, and that's the pediatric care system.
That's a great way to put it.
But then, the moment the patient turns 18, it's as if that highway just abruptly ends. You're suddenly driving on an unmapped dirt road in the pitch black.
And, the underlying infrastructure shortage on that dirt road is severe.
Yeah.
Oh, absolutely. We are talking about a systemic lack of specialized, adult-focused CP care centers across, many global healthcare systems.
Wow.
Now, there are some transition of care guidelines currently being developed to help bridge this gap, but, guidelines on a piece of paper don't magically construct physical clinics,
Right, or train new specialists overnight.
Exactly.
Wait, I have to push back a little here, actually, because a neurologist is a neurologist, right?
You would think so, yeah.
Right. If an adult with CP needs their spasticity managed or their medications adjusted, shouldn't a general adult neurologist just be able to handle basic muscle stiffness? Like, why is there such a massive void when they transition?
Well, it really comes down to how adult medicine is structured and taught.
Okay.
Standard adult neurology training is heavily focused on acquired, progressive, or degenerative conditions.
Like strokes and stuff.
Exactly. Strokes, Alzheimer's, Parkinson's disease, multiple sclerosis.
Oh, I see.
Right. So a static early life brain injury that produces these lifelong dynamic physical effects, it simply doesn't fit into their standard clinical pathways.
Wow.
Yeah. Adult physicians inherit these patients with incredibly complex needs, but their training just hasn't emphasized childhood onset conditions that persist into adulthood.
Which means you have this massive population of adults trying to navigate an infrastructure that practically acts like they don't exist.
That's the reality, yes.
And because that specialized infrastructure just vanishes, the actual priorities of daily care have to shift dramatically. In childhood, the clinical focus is highly specific, right?
Yeah.
The sources outline a massive emphasis on things like tone management and heavy orthopedic surveillance.
Right, lots of monitoring.
Yeah, they're constantly monitoring hips, joints, checking for scoliosis as the child grows, alongside neurological management for seizures, and a huge integration with school-based developmental support.
The pediatric model is naturally focused on physical milestones and, managing a growing body.
Right.
A child's skeleton is constantly changing, so orthopedic interventions like surgeries, skeletal corrections, bracing, they're central to daily care.
Yeah.
But once the human skeleton reaches maturity and the growth plates fuse, those specific constant orthopedic interventions become less of a focal point.
But the underlying condition is still there.
Oh, definitely.
The muscle stiffness, the hypertonia, that doesn't just fuse and go away like a growth plate.
No, not at all. The foundational neurological issues remain. Seizure management is a lifelong necessity, although the sources do note that seizures can sometimes become less severe or stabilize as patients reach adulthood.
Oh, that's interesting.
Yeah. But the tone management, dealing with that chronic spasticity, that remains a daily, lifelong requirement.
So what does this all mean for the treating doctor? If the bone surgery slow down, but the daily management continues, the actual environment of care completely flips.
Totally.
Because the childhood support system, which is so conveniently channeled through the school system, I mean, you have the physical therapists right down the hallway, the special education coordinators managing the paperwork.
It's all built in.
Yeah, but that all evaporates on graduation day. Suddenly, the priority isn't just medical. It's guardianship arrangements. It's long-term financial planning.
And this requires a completely different skill set from the physician. To effectively treat an adult with CP, the clinician often has to step outside the bounds of traditional anatomy and pharmacology. They essentially have to become a bureaucratic systems navigator.
Which sounds completely exhausting.
It is.
You go to medical school to learn how to heal the human body, and suddenly you need a degree in public administration just to help your patient get through the week.
Yeah, because the maze they are looking at is incredibly convoluted. Adult primary care physicians and neurologists managing this population, well, they have to understand the intricacies of state or regional agencies for developmental disabilities.
The paperwork.
Oh, so much paperwork. They have to untangle both federal and private insurance systems, which, by the way, often have completely different criteria for what constitutes a disability in adulthood versus childhood.
That is wild.
And on top of that, they have to coordinate with group home providers, figure out zoning for supported living, and find agencies that offer daytime support services.
I'm assuming none of this is covered in standard medical textbooks.
Not a single chapter.
Wow.
You won't find a module in a neurology residency on how to advocate for a patient's placement in a supportive community day program.
Of course not.
And this structural knowledge gap is a primary reason why the transition of care is so frequently mishandled. The system basically forces families into a reactive posture.
Instead of proactive.
Right. Long-term healthcare planning needs to be proactive. But when the physician doesn't know how the local housing authority works, the burden falls entirely back on the patient and their family.
So families are drowning in paperwork, fighting just to get basic daytime support, completely stressed out.
Yeah.
And while they are distracted by this massive administrative burden on our, unmapped dirt road, something incredibly insidious is happening to the patient's actual physical body.
Yes.
This was the part of the deep dive that really caught me off guard. The clinical decline in adulthood.
It is a heavily underappreciated reality.
Really?
Yeah, a substantial proportion of adults with CP experience worsening gait, declining ability to care for themselves, and a significant loss of balance over time.
See, I always pictured CP as a baseline. Like you have the injury, you reach your level of physical ability, and you just sort of stay there, a plateau.
Right, that's a common misconception.
But for many of these patients, it's an active physical regression.
What's fascinating here is the mechanism behind this decline. The key is understanding the difference between the brain lesion and the clinical course.
Okay, break that down for me.
So the original brain injury that caused the cerebral palsy is static. It is a historical event.
Right.
It is not a tumor. It is not actively growing or spreading. But while that lesion is static, the clinical course, the way the body reacts to it over decades, is highly dynamic.
Because of the cumulative toll of time.
Exactly.
Like if we go back to the hypertonia, the chronically tight, stiff muscles, they are constantly pulling against the bones and joints, right?
Yes, 2047.
So over 10, 20, 30 years, that abnormal mechanical stress doesn't just cause pain. It leads to actual anatomical changes in the musculoskeletal structure.
It literally alters the architecture of the body. You see significant joint malalignment, early onset osteoarthritis, and severe joint instability.
It makes me think of driving a car with a slightly misaligned axle.
Oh, that's a good analogy.
If you're just taking a short trip down to the grocery store, which is childhood, the engine is fresh, and it easily powers through that subtle misalignment,
Yeah.
you might not even notice the extra drag.
Right.
But if you take that exact same car on a decades-long cross-country road trip into adulthood, those tires are going to wear out unevenly.
Absolutely.
The suspension is going to take a beating. And eventually, the entire frame of the car takes a massive structural toll just trying to keep moving forward.
And because of that biomechanical misalignment, Every single movement required significantly increased energy expenditure compared to someone without CP.
Wow.
I mean, the simple act of walking across a room might require 3 times the metabolic effort.
3 times.
Yes. And that leads directly to chronic muscle overuse and severely decreased endurance over time.
And let's layer this systemic physical breakdown on top of the infrastructure cliff we just talked about.
Right.
Just as their body is experiencing this compounding wear and tear, the intensive pediatric rehab services they relied on are just stripped away. And from what I understand, adult insurance often views physical therapy totally differently than pediatric insurance.
That is a critical structural flaw. In pediatric care, physical therapy is funded because the child is, quote-unquote, developing.
Okay.
This system supports growth. But in adult healthcare, physical therapy is largely structured around rehabilitation. The idea of returning a patient to a prior baseline after an acute injury, like a car accident or a stroke.
But an adult with CP doesn't have a pre-injury baseline to return to.
Precisely. And because they aren't rehabilitating in the traditional sense, insurance companies often classify their physical therapy as maintenance.
Oh, no.
Yeah, and standard adult insurance historically refuses to pay for maintenance therapy.
That is so frustrating.
It is. So the vital physical support is removed at the exact moment. The biomechanical consequences of the static lesion are really catching up with them.
The result is completely predictable and honestly enraging. The sources highlight that the two most frequently reported complaints from adults living with CP are chronic pain and chronic fatigue.
Yes.
It's a perfect storm of anatomical wear and tear and systemic abandonment.
It creates a baseline of chronic suffering. And from a clinical perspective, this baseline of daily pain, fatigue, and physical regression creates a highly dangerous environment for doctors trying to treat them.
Yeah, and here's where it gets really interesting and a bit scary, honestly. Because we aren't just talking about general fatigue. The sources detail a highly specific, dangerous complication that happens in patients with dyskinetic CP.
Right.
And since our listeners know that dyskinetic CP involves those constant, involuntary, fluctuating muscle movements, you can start to imagine the physical toll that takes over a lifespan.
Yes. When a patient is dealing with sustained, uncontrolled, and repetitive movements, particularly in the head and neck, it puts immense unnatural stress on the cervical spine.
The neck.
Yeah. Combine those involuntary movements with the malalignment we discussed earlier, and over decades, it predisposes the spine to severe instability.
It's basically grinding down the actual structure of the neck.
It is, and as that cervical instability worsens, it can begin to physically compress the neural elements, the spinal cord itself.
Wow.
This leads to a condition called cervical myelopathy, which typically begins to present in the patient's 4th decade of life, so right around their 30s or 40s.
So picture this scenario. A doctor is seeing a patient in their late 30s. The patient is suddenly dropping their coffee cup, losing sensation in their hands, or their walking is rapidly deteriorated.
Right.
Does the doctor recognize that the spine is collapsing, or do they just look at the chart, see cerebral palsy, and shrug it off as the baseline condition acting up?
This raises an important question about how we train clinicians to interpret symptoms in patients with profound pre-existing disabilities.
Yeah.
It is a well-documented phenomenon known as diagnostic overshadowing. A patient comes into the clinic with a known, long-standing, highly visible diagnosis like CP.
Right.
The clinician sees the wheelchair, sees the spasticity, sees the CP first, and assumes that any new symptom is simply a manifestation of that existing condition.
Like it's just your CP.
Exactly. It's just your CP progressing.
Yeah.
Because clinicians aren't primed by their training to look for a new neurological complication layered on top of the old one, the diagnosis of cervical myelopathy is frequently delayed.
That's terrible.
Sometimes with devastating consequences, yeah. The compression continues untreated. So this is a crucial, high-yield takeaway for you listening right now. Never automatically assume that new or changing neurological symptoms in an adult with CP are just the chronic condition running its course.
That is a lifesaver of a detail. It really illustrates how this purely physical biomechanical cascade can mask entirely new emergencies.
Absolutely.
But we can't just limit our view to the mechanics of bones, nerves, and spinal compression, right? We have to pull back and look at the human being living inside this reality. The sources spend a significant amount of time on the psychosocial burden.
The psychosocial dimension is just as real, and its impact is just as measurable as the biomechanical decline.
Because we're talking about the friction of navigating a society that simply wasn't built for you. The text makes it clear that adults with CP face measurable disadvantages in social life and employment outcomes compared to the general population.
Yeah.
And it's not hard to see why. I mean, imagine trying to get to a job interview when your paratransit is 2 hours late. You're absolutely exhausted from the chronic pain we just discussed, and when you finally arrive, the interviewer sees your mobility aid before they even look at your resume.
Right.
That friction is constant.
And that constant friction takes a profound toll on mental health. The data provided in the sources shows that the prevalence of depression in adults with CP can run as high as double that of the general population.
Double.
Yeah.
That is a massive spike in prevalence.
It is. And if we connect this to the bigger picture, it ties directly back to our discussion about the physical regression. These higher depression scores directly correlate with higher levels of functional disability.
Well, that makes total sense.
Really?
As the body experiences that misaligned axle wear and tear, as the daily pain and fatigue skyrocket, and as their hard-won independence starts to slip away in their 30s or 40s, the mental health toll naturally rises in tandem.
Right.
They are intricately linked. You can't separate the physical from the psychological here.
They are entirely interdependent. A clinician cannot effectively treat the orthopedic decline without acknowledging the depressive symptoms.
Yeah.
And they cannot address the depression without understanding the grief of losing physical function and the sheer exhaustion of fighting a medical bureaucracy just to get physical therapy. It demands a holistic, comprehensive approach to care.
Which brings us to the grand synthesis of everything we've covered today. We started by shattering the myth that cerebral palsy is just a condition of childhood, isolated to brightly lit pediatric wards. We learned that the care for CP cannot and must not end when a pediatric orthopedic surgeon discharges a patient, or when someone ages out of the school system's support network.
It is a dynamic, lifelong journey that requires lifelong management.
It requires clinicians and families to become expert systems navigators, fighting through the tangled webs of adult insurance and regional agencies just to secure basic daytime support.
Right.
It demands absolute vigilance against new, hidden neurological traps, like cervical myelopathy, where we must constantly remind ourselves never to assume new symptoms are just the CP.
Exactly.
And it requires proactive, compassionate psychosocial support to combat the isolation and the depression that so predictably accompany this physical decline.
The transition from a static pediatric view of CP to a dynamic lifespan view is more than just a medical necessity. Understanding this paradigm shift is crucial for anyone navigating, managing, or working adjacent to the healthcare system.
For you listening, whether you are a medical student figuring out your specialty, a policymaker dealing with insurance regulations, someone living with a chronic condition yourself, or just someone trying to understand how our world works, this matters.
It really does.
Because it shows how easily massive, sophisticated systems can become totally blind to the people standing right in front of them, simply because their biology doesn't fit neatly into a historical textbook definition.
And that leaves us with a final, lingering thought to explore. If our deeply established medical infrastructure possesses such a profound systemic blind spot regarding the adult realities of a condition as universally recognized as cerebral palsy, well, what other childhood onset conditions is our healthcare system systematically abandoning the moment a patient blows out 18 candles on a birthday cake?